representatives from the Filipino, Micronesian, and Native Hawaiian communities in order to talk about what their perspectives of issues with mental health are, and also some recommendations that they have. And particularly, we invited this group and these panelists because not only are they a part of the communities, but a lot of their work that they do also align, and they have current projects that they're doing as well. And so to introduce our panelists, we have Erin Henderson Lacerdo, Dr. Dela Cruz, and Davis Reuher. So if you could give them a round of applause, and they'll introduce themselves as they speak. So let me share screen.
Hello. All right. Aloha mai, everyone. My name is Erin Henderson Lacerdo. I am an LCSW, I clearly typed that wrong myself, specialized in supporting mental health for infants and young children. And my work history really had me working in home visiting. So I worked a lot in home visiting, both as I guess I would say prevention-based home visitor, as well as a therapist, doing work to support first relationships. And I am trained in multiple evidence-based curriculum that demonstrates the improvement of attachment relationships. So that's kind of the context that I come to you today. And I work at the Association for Infant Mental Health in Hawaii. And what we do is really hope to get together a lot of the professionals, that includes all of you, who can help to support the first relationships of our youngest. And so we really do want to empower the community through providing support in workforce practices, policies that can help to really create a strong and healthy environment for our youngest. So when I say our youngest, I'm really referring to prenatal to 5. So that's really my specialization. And so I do hope that I can share with you, I'll be sharing with you a few things about infant mental health. So it's kind of a funny presentation today because we're really putting together like our specialized training, but what is also important is that we are also people providing services in the community. And so we cannot separate who we are from what we do. And so with that, I'm gonna share with you a little bit about infant mental health, and then a little bit about some Native Hawaiian perspectives as well. So to get started, in case you guys didn't know, babies have mental health. And so I have this collage here. This is my son. He's now 3. He was still only 2, I think, by the time I put this together. But in just a few frames, you can see the many, many emotions that a toddler can have, an infant and a young child can have. You can see happiness. You can see warmth. You can see curiosity. You can see disappointment, perhaps, and even some maybe scaredness or fear. And so many times, there are people who believe that babies really don't need to be thought of, or we don't need to concentrate on them. And yet, if we look at their faces, they're telling us that they do indeed have feelings, have emotions, and have mental states, just like adults. And so we can really do a lot if we can start here at this young time. We can really set up a trajectory of life that can be healthy and build resiliency. And so we really do want to remember that babies do have mental health, that they do remember, and that even though they're tiny and they might not be able to say things the way that we do, they still do have memory in their bodies and in their minds. So I wanted to just do a couple of quick definitions of infant mental health. And many times we'll hear of developments shared about in domains, right? We have cognitive, physical, I'm blanking on them, of course, right now, but one that we often talk about is social-emotional development. And a definition of that is that within the context of one's family, community, and cultural background, social and emotional health is a child's developing capacity to form secure relationships, experience and regulate emotions, and explore and learn. And when we look at the definition of infant mental health, it's really both a practice and a premise. But one way to look at it here is that it's defined as the optimal social, emotional, and cognitive well-being of children 0 to 3, developed by secure and stable relationships with nurturing caregivers. So what's really important here is that the relationship of this child to the caregivers in their lives, it's what's critical and crucial for development. And so often we look at children just by themselves. But in reality, babies can't survive without an adult who cares for them. If we were to leave a child on the street somewhere under the age of 3, there's very little chance that child would make it, right? We left an adult out there, we might have different odds. But for our littlest children, we really have to consider the context in which they live when we think about their ability to understand their emotions, regulate themselves, and develop secure relationships that will last a lifetime. So, as we say, if we care about babies and young children, we must care about the people who care for them. So when we all thrive in healthy, nurturing relationships, and our babies need the same. And so when babies feel safe, they can then develop that healthy attachments to their caregivers. And so it's really important to remember that babies do not grow up all by themselves, that their mental health is truly dependent on the environment around them, and that environment typically comes in the form of a caregiver. Okay. And so, are you sure? Yeah. No? Or was it just blue?
Yeah.
Poor thing. Oh, poor thing. Okay.
Haven't had technical difficulties all day, and I wanted to do it right now. Let's see. Okay, let's try this one.
At least they can see that.
Did it?
Yeah.
Okay. Okay.
Okay, thank you. So I could talk for a very long time on infant mental health, but that's not technically the topic for today. So I did want to kind of move us in a different direction of also understanding the Native Hawaiian perspective of children. And so as a Native Hawaiian, there's a lot. I was actually talking to a friend the other day about how, there's certain stigma tagged to mental health, especially in our Native Hawaiian community. And so we were talking about that because he too is a clinical psych who's Native Hawaiian. And obviously we believe that mental health is a thing because we've specialized in it. So I just wanted to share a couple of Olelo no Eau. So if you're not familiar with Olelo no Eau, these are wise sayings that Tutu Mary Kavena Pukui put down on paper for us. And a few of the things that she said include the knowledge of the parent is absorbed by the child. So if we think about this Olelo no Eau just by itself, it really speaks to how the Hawaiians knew that the parent was very integral to the development of the child. That the child was dependent truly on how this parent was able to share their ike, their knowledge, their ways of life with this child. And this one is a little more poetic, I guess. But imaikai ke kalo I ka oha, the goodness of the taro is judged by the young plant it produces. And so when we look at the way kalo grows, and kalo is typically used as a metaphor for ohana or family unit, but the way a kalo grows, this is what is so fascinating to me. Does anybody here know how kalo grows? No kalo farmers in here? Okay, I'm not one either, but what's interesting about kalo is there's actually no seeds. So if you have a kalo plant that has been grown from what they call runners. So a kalo will grow and it'll develop a runner, and that'll produce a new plant. And so every kalo plant that you see today is quite literally the descendant of another kalo plant from generations ago. And so when we think about the ohana as a unit like that, then we see that the child, right, is an offshoot of the parent. And I don't want to confuse anybody and say that, like, I believe that all parents, like bad children, are because we have bad parents. That's not what I'm trying to say. What I am trying to say, though, is that if we can create a strong foundation for the runner to develop or for the keiki to develop, then that keiki has a much stronger ability to be able to flourish as they grow older. And so we do believe as Native Hawaiians, you know, if we look at the family as a kalo plant, and we do believe that our greatest ancestor was indeed Haloi Kalau Kahali. So it is very important for us to remember that the way kalo grows is also the way the family unit grows. Okay. So I also wanted to include a little bit about infant mental health in particular with the Native Hawaiian perspective. And a few things that I've learned over the years is that truly hapai or pregnant women were really revered. You were not to speak ill of these women. You were not to speak ill in front of them either, because they believed that what this mother was carrying was gonna be impacted by whatever was around her. Babies were also viewed as being connected to kupuna through piko. So there are 3 piko that Hawaiians have, right? We have our piko-E, which is up here, and that connects us to our ancestors. Your piko-A, which is your belly button, and that connects you to the to your like current generation, and then your piko-O, which is your genitals, and that connects you to the future generations. So it's really this like cyclical way of looking at life. And what is also believed is, you know how we say babies have their soft spots, right? And so that is one of your piko. And so Hawaiians believed that babies were so precious because their soft spots were still there. And what that meant was there was nothing between them and the ancestors, that they could still speak to the ancestors. And so this tells us, to me anyway, this makes the case for how special and how important babies really were to Native Hawaiians. And so lastly, you know, we may be familiar with the Ahupua'a system, for example, of how Native Hawaiians lived in a very symbiotic way with nature and with each other. And so when we think about our Native Hawaiian families, right, they really came from a history of people taking care of one another, of people working together, and of recognizing that we all have a role to play in the greater community. And so we can, you know, extrapolate that to see how we can care for the mental health needs of our Native Hawaiian community members if we can embrace some of these facets. And so I will close my section here with just this saying here that when babies have safe and nurturing relationships, they become healthy and resilient adults. And so what we can do when we focus on our youngest years is really have the ability to make change, to interrupt intergenerational trauma, to promote intergenerational hope, and to really build a bright future. The earlier that we can intervene. This is a very critical time period for brain development. And so when we are able to set those pathways very clearly for them, then we're just doing a whole lot of really good things. So that's it for now. I will pass it on to my colleague here. Dave. No idea how much time that was.
Thank you, Erin. Good afternoon. Thank you for coming out and hanging out with us. It's the last session of the day, and I've been to conferences where it's kind of last session of the day is not as many people, so I really, really appreciate you guys coming out. My name is Dave. Reuher. I'm from Palau in the Micronesian region. I'm a PhD student at the University of Hawaii, Manoa, in public health. And I study mental health and suicide prevention. Prior to going back to school, I I worked at the Department of Psychiatry at the School of Medicine for a long time as a research associate. We normally worked on Native Hawaiian and Pacific Islander mental health. Didn't really get a chance to work on Micronesian stuff, so I'm really fortunate right now to my project. It's allowed me to do that. So I'm going to talk a little bit about Micronesian mental health. There's not a lot of data out there, but there's a lot of needs that need to be addressed. Normally, this presentation takes like an hour and a half, and I have to do it in 15 minutes. So there's going to be a lot of slides there that I left. I'm not going to really address, but I did that on purpose because I want, if you are interested, to have a copy of the slides and all the other information on there. And if you want to contact me, then we can talk about the other stuff. But normally, it takes me about a half hour just to talk about context, because it's really important to, when you talk about health outcomes, to talk about context, because nothing happens in a vacuum. And not many people really know the history and colonization of the Micronesian region. So I've spent a lot of time going over that, and then I get into the health part. So I'm gonna run through that really fast, touch a little bit about mental health, and then I'll get to what I call the cultural considerations for those of you who work with Micronesian patients, for you kind of think about as you deal with their patients. So those on the right, that's kind of how we say hello in the various languages. And I just start off, and I know all of you are familiar with this, but I just kind of need to reiterate where the Micronesian region is. So to the right, there's Hawaii at the top right, and then Polynesia in the gray to the right, Melanesia on top of Australia in blue. So Melanesia means dark islands, Polynesia means many islands, and then Micronesia in green in the north is small islands. So this is kind of how these terms are really problematic in and of themselves. They were turned by Europeans way back in the day, but it's just kind of easier to use. So just to give more context, so if you're looking at the Micronesian region, so Palau, where I'm from, is in the west, and the Marshall Islands in the east. You can fit the whole continental US in that space with room to spare. So we're talking about a very large area. And then to the right, what you're seeing is a map of the Federated States of Micronesia, which is made of four states. And as you can see, there's many, many islands in there. So it kind of presents issues in how to deliver care, because a lot of the islands are literally islands. But if you're familiar with Epeli Hau'ofa, who was a Tongan writer, he actually, most people think, these are islands in a vast sea, kind of reframed that, and actually it's a sea of islands. So the sea connects all of the islands together, which is a really great way of looking at it. And that really reflects Pacific Islander communities, right? We're all connected, families, communities. There's a lot of connections there. You'll see to the right there, I kind of put in, so that's first child birth ceremony in Palau. What I really want to do is also increase awareness of Micronesian culture, but there's just no room for that. So I just stuck that there to show that there's hundreds of cultures, 100 years of culture for these countries as well. And I would really love for people to know more about that. So I'm not going to really address those, but I just want to show you why. You'll see those kinds of images there. So when we talk about USAPI, which is the United States Affiliated Pacific Islands, so these are islands affiliated with the United States. So there are two that are territories, Guam and the Northern Mariana Islands of CNMI. So if you're born there, you're an American citizen. If you're born in the other three countries, so Federated States of Micronesia, FSM for short, Marshall Islands, and Palau, those are what's known as the COFA countries, Compacts of Free Association. So some of you may have heard that. If you're born there, you're citizens of those countries. But we have a special relationship with the United States that allows us to come in and work and go to school, and I'll talk about that in a little bit. But when you talk about USAPI, these are the territories and countries that we're talking about. So again, this is just a little snippet of the historical trauma that's actually affected a lot of indigenous populations. And when they contact the West, there's colonization, steep population decline. World War II had a big effect on the region. And there's just a lot of things going on there. World War II, actually, not many people know this, but World War II had a huge, huge impact on the Micronesian Islands. The war between US and Japan really affected the Micronesian people from the marshes all the way to Palau. And a lot of things happened that's historical trauma that really has not been studied. And so I hope to actually do one of those while I'm in school. but I just wanted to show that, there's these things happen in the region. Nuclear weapons testing in the Marshall Islands, you may have heard of this. Right after World War II, the US Navy started nuclear weapons testing. Overall, about 67 nuclear tests that combined were more than 7,000 times the size of Hiroshima. And it has effects to this day. They literally blew up an island. This is kind of a macabre thing, but all of you know a Marshallese word, and that word is bikini, the two-piece bathing suit, because that name came from these testing. Because the guy who designed it, he capitalized on the notoriety of the nuclear testing, because the two-piece bathing suit at that time was very, in social circles, was kind of explosive in its own way. So he based his thing on that. And also, the animated show that's super popular with Squidward, I can't remember the name right now. SpongeBob, yeah. That's where they are is at the bottom of this thing in the Marshall Islands. So that's where the setting is. So there's been millions of bucks made off of what's happened here. And none of that has been returned to the Marshallese, just to give you an idea of what's happening. So the COFA for the FSM and Marshall Islands started in 1986. For Palau in 1994. The reason why is there's a whole, I don't have time to get into it, but involved presidential assassinations and shooting of lawyers. So Palau is a really, they're all young countries, but Palau especially kind of had a hard time getting the COFA thing in place. But COFA allows for these freely associated states to come into the US to work or school without having to go through the visa process. It makes it a lot easier. To that we can go back and forth. But if you commit crimes here as a Micronesian, you'll be deported. What does the US get out of it? Military and strategic rights. Basically, that's all they want. The area is very strategic. It's right, back in the day, it was for Soviet Union. It's kind of right back door of the Soviet Union. Now it's China, and Russia is starting to kind of reset, and North Korea as well. So it's a very, very strategic area, and the United States military wants to hang on to it for as long as it can. So this is the exchange I made. You can come into the US, but in return, we're going to control military that whole region over there. Just some selected economic and health indicators. This is actually kind of old, so I'm not going to spend too much time on this. Top 10 causes of deaths in the region: heart disease, stroke, diabetes. Actually, diabetes is an epidemic, obesity as well. And self-harm. Actually, Palau is not listed as it should be. It's also an issue here in Hawaii, not so much national. So migration, I just want to show data. There's been a large increase in migration of Micronesians coming to not just Hawaii, but Guam and the United States as well, the rest of the United States. And the reason for that is the US, when I didn't mention it, but there's what's called the Trust Charity of the Pacific Islands. When after World War II, the United States was supposed to help these islands develop to be self-sufficient. That never happened. And so what's happened is kind of a culture of dependency where none of these were really developed. So there's high unemployment, education system is not great, healthcare system infrastructure is not great either. So we are having to come here to look for those kinds of things. So just at the bottom there, you'll see there's Hawaii has the highest number of COFA migrants at just under 25,000. I believe that's an undercount actually. And this was done before the 2020 census. Just to give you an idea of overall numbers is very small, but the increase is very high. So I'm going to switch to talk about mental health. There's not a lot of data here, but it's what is there is very concerning. So we have data from the Federal States of Micronesia. There's data from Palau and the Marshall Islands, but it's kind of old, so I didn't really feature it. But figure 1 to the left looks at suicide rates by state. So as you see, Kosrae is 15.7 deaths by suicide per 100,000. That's the rate. Pohnpei and then FSM, Chuuk, and Yap has the highest at 29. So these are all higher than the global rate. The global rate is about 9 deaths per 100,000, and the US is about 12. So as you can see in the islands, it's very high. And this has been like this for a long time. Figure 2 is looking at the percentage of suicide that's by age group. So 15, under 15, first column to the left, and then 16 to 20 age group, 21 to 25 age group. And as you can see, the 16 to 20 age group, 28% of that group accounts for all suicide deaths, followed by the 21 to 25 age group. So youth and young adults account for most suicides in Micronesia, and actually this is true of the rest of the Pacific region and of Hawaii as well. It's really unique to the Pacific, and we're not really sure why. And then as the population ages, lifespan ages, then it goes down, and kind of that reflects as people age in the Pacific Islander societies, they become kind of valued for their wisdom, and they find a place that they're valued, whereas youth are kind of lost. So looking at Guam now, so Guam is a U.S. territory, so my Micronesian migrants go to Guam because it's right there, and you're seeing the same thing. This is by age group, my Micronesian migrants by age group, so under 15, and then the highest are the youth 16 to 20 and young adults 21 to 25. So we're seeing that there for Micronesian migrants, and interestingly, Chamorro, who are the indigenous people of Guam, their data is also really reflective of this. Their young people have the highest rates for that population. And this is Hawaii. This is data from the State Department of Health. Sorry, I don't have exact numbers because I didn't have that when they gave it to me. But this is suicide rates by ethnicity. And as you can see, the Micronesian off to the right has the highest, just around 300 deaths per 100,000. Again, this is rate. The overall raw numbers are small, but the Micronesian population itself is also very small. So when you convert it to rate, it's really high up there. And I don't have the slides. I don't know why I didn't put it in there, but when you also break it by age group, Micronesians have the highest, followed by Native Hawaiians for the teens and young adults. So the data really reflects what's happening in the Micronesian Islands and in the rest of the Pacific. So this is just kind of a reflection of what I just talked about, our summary of what I just talked about. So what we want to do is kind of look at study kind of context-specific programs to kind of address what's happening, because Micronesia, we say Micronesia, but it's very diverse. We speak 23 different languages, so that kind of presents challenges there. And then this study looks at anxiety, depression here in Hawaii among Micronesian migrants, was just released last year. So what they found was, because of the connections within Micronesian communities, they were less likely to experience anxiety. Didn't really have any findings for depression. So we want to enhance cultural pride and connections to mitigate anxiety. So I'm going to switch over to what we call cultural considerations for those of you who work with Micronesian patients, clients. If you're a provider, a psychologist, a physician, a social worker, or even an administrator. Some things that you might want to keep in mind when you're working with your Micronesian clients or patients. So this was given by Dr. Sheldon Ricklan, who's from the Marshall Islands, but he trained here at JAPSOM, and then he taught at JAPSOM for many years. He's a family health physician. And then he got recruited over to Arkansas, because Arkansas has a huge Marshallese population. There's about 15,000 Marshallese there. So they recruited him over there. But he gave a talk, and he kind of gave, based on his experience, what you want to do when you just think about when you're working with your Micronesian clients or patients. So there's over 20 languages. The one common language is English. That's the one common language that we all can understand. So as a Palauan, if you ask me, if you have a patient who's Chuukese or Yapese, for example, and you ask me, and they don't speak English well, you can't ask me to interpret because I won't be able to help them. So you have to find people from their own culture. Again, we have different cultures, customs, and protocols. Family comes first. That's really typical of Native Hawaiian and Pacific Islanders as well. Religion is a big deal. Christianity, group needs are important. There's preference for peer and group interaction, not so much doing things on your own. And this just kind of looks at kind of the differences. Again, I'm generally speaking, not each and every Micronesian is going to be like this. So kind of like how Micronesians kind of look at life compared to Western, for example. So for example, we're kind of focused on present today now, as opposed to looking to the future. Another example is extended family is very important, as opposed to the nuclear family. That's kind of changing. And then the other thing too is consensus and confrontation. And family development is also very important. So everything an individual does, like if a youth goes to school, it's understood they're going to go back and then contribute to the family. Parenting roles and patterns. what's to be get from here is that parenting is a shared extended family obligation. Children are really expected to learn by observation. So an example of this is at a school setting, a teacher might ask a Micronesian student, do you understand what's happening? Or they give a lesson, for example, and then they ask, do you have any questions? Micronesian youth probably won't ask because they're not used to that. They're used to just sit there and observe and learn. But the teacher actually expects the students to ask questions. So there's already a disconnect there in the student. The teacher might like, they probably don't care because they're not asking me questions. Just one example of that. Taboo topic is sex. Really inappropriate in the presence of the opposite sex and in the presence of family members. So you might want to, if you need an interpreter or provider, be in the same sex as much as possible. Yes, so this is not unique to the Micronesian population, but just something for you to keep in mind. Yes could mean three things. Could mean yes, could mean no, could mean maybe. And so you're working with a patient and you're like, you just prescribe some medication and then you're like, okay, go pick up your medication, do this, do that, come back in a month, and then we'll go over, how it is, and then we'll go from there. Do you understand? If you get yes, we kind of dig a little deeper than that. Because yes, if it means yes, they truly understand, that's great, that's the outcome we want. But it also could mean no, and it also could mean maybe, because there's this power dynamic between the physician and the patient. And they're thinking if they don't understand and they say no, they're disrespecting you. So they cannot disrespect the person they perceive to be in power. So they'll say, yes, I understand, even though they really don't. So it's really, really important to say, you know what, it's okay to say no. It's not on you, it's on the both of us to come together and understand this. So it's a way to avoid confrontation, getting out of uncomfortable situations. And it's also okay to tell them, can bring a supportive person along as well. Unfortunately, some attitudes toward mental health is still like black magic, so you can't really do anything about it, unfortunately. We still see that. Expect language barriers. The Micronesian population is, there's a lot of, it's very stigmatized, so that may prevent them from actually wanting to engage with you. It's not because they don't want to work with you or they want to work on themselves. They're just like, if I say I'm Micronesian, I'm going to get, oh, it's your type again. And that just shuts them down. Yeah, and that's all I have. So I kind of zoomed through that, but that's my contact. I do a lot of awareness presentations for free. So please, if you want me to come and talk to your group, email me. I'll be happy to talk with you. Thank you. I didn't have time for this, but you can look at the bottom of the slides to kind of show. I like to show the islands are for real. It's there. So just kind of, if you have time, go through it and look at it. Let's get through all that.
Good afternoon. Give me 1 second. Okay. So I'm happy to say that I recognize a few of you in this room, so it makes me a little bit more comfortable. Hi. So this isn't going to be too formal because I know some of you already, but my name is Dr. Joseph Gary Dela Cruz. I go by Dr. Gary in my office. I go by Gary. My friends and family call me Gary. The Joseph is just formal. They just wanted to name me that because they thought I couldn't get baptized with the name Gary. That was what they're. So, I practice alongside my father, Dr. Edgar Dela Cruz, in a private practice on Dillingham Boulevard in Kalihi. I have a diverse patient population, excuse me, but the majority of my patients are Filipino. The reason I'm here is, as you can see in my slide, it's about Filipino mental health and PMHCA, which stands for Pediatric Mental Health Care Access. And I thought I'd start off my lecture by telling you a little bit about my practice and the patients I see and what I've been experiencing over the last 18 little over 18 years now in my practice. My patient population is pretty diverse, but of course, I work in Kalihi, and the majority of my patients are Filipino. And they're just not in Kalihi. My father started working here back in 1981, and when his patients ended up becoming parents, Honolulu was becoming a little too expensive, a little bit too small, a little bit too tight. So they all moved out to Eva, Waipahu, even as far as Kahuku and Waianae. But we're lucky that they are loyal to our clinic and they yet still decide to come all the way to see us. What I'm going to share with you is the experiences I've had in dealing with my patients, specifically the Filipino population, and identify some of the obstacles and barriers and challenges when taking care of my patients when it comes to mental health. But just as Dave pointed out, these challenges are not unique to the Filipino population. They're not unique to the Native Hawaiian population, to the Micronesian population. A lot of these challenges could apply to all cultures in Hawaii, from Chinese, Japanese, all of us, basically just because of the stigmas and just the way parents really view their child and how they view mental health. So again, my focus here is to speak about the Filipino culture, but again, it is not unique. So how this starts in my office, I'm just going to start taking this off for a sec. When I see a patient in my office for a well visit, we call them a child visit, well adolescent visit, preventive care visit. It starts off with the parents signing their child up. But if you're 12 years old and above, you start getting screened. And that's a pretty new thing for a 12-year-old. The reason why it's 12 years old is for two reasons. Number one, we're mandated by the insurance company. Well, I won't name the insurance company. We're mandated by a insurance company to start including this in our billing. So that's kind of how it started, but the intent was good. It was to start screening for depression and anxiety for our patient population. All right. So they fill out the form. They're supposed to fill it out on their own, but you see, as a Filipino myself and as a parent, I might be inclined to look at my 12-year-old and say, hey, what are you filling out? And sometimes you'll get the parent filling it out for you. So that's one challenge, I guess you would say. I remind my nurses, just tell the parent to back off. Just give them the clipboard, let them fill it out. I like to see what they say. And for the most part, they comply, right? And then the vital signs are taken. I'll get the patient in my room. I'll look at the chart first, see what that screen said. And hopefully the patient's fine. However, you will get a 13, 14, maybe older with a positive screen. And if you're not familiar with these screens, I'm sorry I don't have a slide of it, but it's called the PHQ-4. We also use what's called the PHQ-9. And these are questions specifically asking about anxiety and depression. All right. And then we score it. But I just want to mention that scoring doesn't say everything, right? Once you get a score of anything, you should, well, I do anyway. I do tend to ask more questions. When the parent and the patient come into my room, we introduce, we say hi, we talk story, examine the patient. I do give the vaccinations if necessary, right? But then if I do get a positive screen, I'll ask the mom or the dad, whoever's with the patient, if you wouldn't mind giving me 5 minutes with your child, I'd like to speak with him or her alone. And that's an allowable thing. Some parents don't understand that. Some Filipino parents are like, yep, I'm out of here. Go for it. My kid needs help. It's kind of one of those things where the parents are like, yeah, anything you want to say. But you get an immigrant family, fresh from the Philippines, and they want to understand what's going on, right? And that's where my challenge lies. I have to find a way to tell the mom, hey, or the dad, excuse me, everything will be fine. I just want to get to know your daughter or your son a little bit more. And then they'll be okay about that, right? When I find out that the patient actually needs a referral and how urgent the referral needs to be, it's then when I run into a challenge, because there are different types of referrals. There's the urgent referral, and there's the referral that can wait maybe about, well, in some cases, unfortunately, 2 weeks to 2 months to even 4 months or 6 months, depending on who you need to refer to. In my experience, excuse me, there's three things that may happen. Number one, I need to get this patient immediate assistance. This patient may be suicidal. This patient might be a danger to himself or to others. And I have to find a way to get the patient help. The second type of referral is somebody that needs an actual referral, but it could be a while, and I'll set something up, whether I call somebody I know, a psychologist, an LCSW, maybe a psychiatrist, and follow the patient as needed. And the third type of referral I have is somebody that I think I can take care of myself, where you don't really have to just start panicking and look for somebody. But if you build a good rapport with the patient and hopefully their parents, you can kind of trust yourself that, you know what, let's have you come back in about a week and we'll talk again. And those are the big reliefs I have. Those are the patients I actually will hopefully see. They'll actually come to my office, I hope, and set them up with an appointment. But you see, the problem with all three, like I said, all three are different. But the problem with all three in my patient population is that, as I was saying, the parent might not really understand what I'm doing and why I'm doing such things. They thought they were just going to get their kid a shot, give my kid the shot, tell me my kid's fine, and I'll be on my way. But it's almost like a sneak attack because they don't really know what just happened. All of a sudden, I'll talk to the kid, and I joke with my dad when it started happening. I'm like, oh, hey, I call him Pop. Hey, Pop, I just made another kid cry in my room. Wow, what happened? And they're telling me stories about school or bullying or, lately it's been a lot of sexual orientation where they don't know how to talk to their mom and dad, who, just as Dave was saying, it's a lot of religious aspects that we deal with. I'm seeing that a lot, but it's knowing who and how to help is the problem. So what have I done? It's either, I'm lucky that my particular physician organization has an agency where I can actually just fill out a fax. Fax it right over. They're assigned a care coordinator or a social worker, and they'll get me help. And I'm very fortunate to have this particular agency helping me. But I know a lot of my other pediatric friends don't have such luck. Yeah, they're on their own. You're on an island. What do you do? Who do you call? Who do you talk to? Excuse me. Then comes a subject. This is what I was going to talk about last and kind of go into my PMHCA. They're always like, well, Gary, there's telehealth. You can just have somebody get on that FaceTime and start, helping your patient out, which is terrific. I only have, all right, darn it. Okay, I got 4 minutes. So I'm I didn't even get to my slides yet. Sorry, but that's okay. I think this is better, but I just want to talk to you what I've been doing, okay? Yeah. All my slides is about what PMHCA is, and I'll get to that really quick, but it's okay. I think what's important, okay, my guys are telling me, don't worry about that. Just talk about you. All right. Maui, I mean, we can probably talk about this later, right? Maui just, you know, it kicked all of us in the ass. I mean, it just really did. And it's going to kick us in the ass. Excuse my language. There's no kids here. It's going to keep kicking us in the ass for a long time. And there's two things about this, okay? Number one, I have a lot of psychologists who I refer to and LCSWs. Gary, if you want me to see this kid sooner, they gotta agree to telehealth. I'm like, there's no way I can fit them into my schedule. But if they agree to a telehealth, I'll see them. And I'm like, hey, that's all I've got. Thank you. I'll take it. But you're a Filipino parent. You're from the Philippines. And all of a sudden, some stranger is FaceTiming your daughter, and you're wondering why your daughter's crying in front of this FaceTime. I mean, it's meant to help, and I get it. I want it to help. But this is a cultural obstacle that we have to figure out how to deal with, all right? In the little time I have, I'm not saying telehealth is wrong. I'm saying it's what we have. We're going to make it work, right? But in my experience, and something that was brought up in a meeting that I just had 2 days ago, it's better to have the patient not so much on a telehealth with you, but to ensure adequate follow-up with that patient who's on telehealth. If I just tell my patient, hey, here's your telehealth person, they're going to give you a call in a week, you talk to them, good luck, adios. Hopefully it works out, right? I always, and I can't speak for everybody, but I always make sure you have your patient come back. That's what I tell my patients. How did that telehealth visit go? How have you been helped? Did they make you feel better after your visit with them? And in most cases, when they have them come back in a week, like a week after the telehealth visit, they'll actually tell me, you know what, they told me this and this and this and that, and it actually was better, right? So in the 1 minute I have, what PMHCA is called, it's Pediatric Mental Health Care Access. And what we are doing, I'm the vice president of the Hawaii American Association of Pediatrics. I am also the pediatric mental health champion I was assigned by Dr. Tony Guerrero, who's on this, he's actually online right now. But everything kind of worked its way magically into my role, where we're actually getting advice from other doctors in Hawaii. We've actually flown to Maui. We've flown to Kauai. We've flown to Kona. We still have to go to Hilo. I still have to meet with the pediatricians here on Oahu. Not even just, that's easier said than done, because look, we're here in town, but there's also the west side. There's pediatricians on the north side. There's pediatricians everywhere. We don't know what they need, but we are gathering info. And what we're finding out from everybody, especially in the outer islands, is that there's just not enough people. There are just not enough specialists. There's just not enough people to talk to. What we're trying to do with the Department of Health is give advice and work with the DOH. I know my guys are nodding at me. We're trying to get something called the warm line, where if you're a pediatrician, you don't know what to do, you're kind of stuck. Where do you go? Who do you call? We're trying to set something up where you can actually, where the primary can actually call somebody and speak to an actual psychiatrist and say, hey, what do I do here? This is what I've got. And the hope is that that psychiatrist will say, all right, Gary, we're going to try this. You can try this medication if you want to try it. Don't forget about this. Did you ask about this, et cetera, et cetera. And that's what I'm trying to do here. And I think I'm out of time. Thank you.
So we have like about 30 minutes left, and we just want to open it up for discussion with all of you. And then if we have some time, the panelists can also ask each other some discussion questions, but we want to answer, of course, your questions. And with also for the people on Zoom, I think we actually have, let's see. Actually, okay, no questions from the Zoom yet, but if anyone has questions.
Actually, can you hear me? I have comments and not questions, because I want to thank you both remind me my cultural background. It was so similar. I'm so amazed. I was born in Taiwan, but I'm more American than Chinese now. But now you made me think back my Chinese culture. Because when you had that picture that the Hawaiian culture compared with American, it reminds me that Hawaiian is so Chinesey. I'm sorry about that because those cultures are so much ingrained in my brain from Confucius teaching about the family. And I looked at the map there, Taiwan, which is below Japan. So I think that now I think back when I went back to Taiwan, the Aborigines, I begin to think of why Aborigines look so much like Hawaiian or with grass skirts. I begin to think that, I mean, we live in America for so long. I went back to visit my own country. I said, wait a minute, what is this connection is all about? And I think that from that whole chain, the island had communicated somewhere that Chinese old culture, Asian culture had brought into here that, I don't know, it's just my trying to analyze the situation. I'm so excited that I'm connected with you, all of these things. I feel like my blood is just boiling. I'm so excited that I feel this connection. And is that right? Am I thinking correctly, sort of?
Yeah, I think so. I think you're on the right track. there.
There's
I
some
believe that.
influence, right?
Yeah, from the time, yeah.
Yeah, from that,
Mhm.
because it's just so similar, family,
Yeah.
culture, and obedience is so much different from the Western.
Mhm.
But I adopted to the Western and I feel like freedom and free speech. But if you free speak in where I grew up, that you get smack on the face. You just listen to the parents. But here I dare speak. So because I'm American now. And the other one is more power to you for the pediatric mental health, because I know that a lot of, I don't want to generalize, but Chinese are very denial of family, of the mental illness, because it's sort of like a shame of the family. You don't talk about your family stuff outside. So I do have an adult, I'm a family medicine practitioner. I also have an acupuncture license. So I have an adult Chinese woman came to my office. She talked about all of her depressive thing, but at the end of her office, she said, do not put depression on my diagnosis, because she feels ashamed. She tell me how to write diagnosis for her. I'm American, I'll write what I feel it is, right? But this is how the culture is, right? That it's a shame of mental health. So I give you a lot of credit, Dr. Gary.
Oh, sure.
Dr. Gary, it is hard to take care of pediatrics mental health because you have to deal with parents and their denial. Am I right?
You're absolutely correct.
Thank you. I'm not here to generalize, but I just feel like we're connected. We're very much connected with all this mental health, our culture, our ancestor, and what are we going to do here in the island, in the country I love, United States of America. It gave me the freedom to be who I want, who I am. That's the country I love. Thank you so much.
Thank you.
I don't have
Thank you so much.
questions. Please, I promise.
Getting my steps in today.
I'm so glad I have attended this session. I learned a lot from all of you, and it also validates some of the thoughts that we have. I'm not from the health side, I'm more from the workforce side, but I'm now in the mental health, adult mental health in particular. But for Filipinos, and I think micronations and all that, this thing about family needs and really needing to contribute back home and to your families, I think is going to really be a big one of those adverse conditions that will affect a lot of those in Maui right now. Because I think I'm reading, maybe my question really is, okay, I'm reading all the studies, right? That we already know that there's going to be a lot of adverse conditions, several adverse conditions affecting especially the children, loss of home, loss of family. loss of loved ones, loss of community, and then us not knowing what to really do. So my question maybe is, do you have any thought processes on how we can expand maybe the support group or the people who can help with the resilience aside from the health profession or even aside from the mental health? I'm so glad that you opened up, like primary healthcare will be helping now. But I'm just trying to look for where else can we maybe train people, prepare people so that we are ready for helping Maui, but also helping ourselves, because let's face it, that's not the only disaster that's going to be happening in the next, we're in hurricane season, El Nino time. Honestly, right now, I'm still in panic of what we're gonna do if something hits us. Basically, my question is, where is our support group that we need to provide more technical assistance, more training, so that we can help you and we can help ourselves?
So we had some meetings yesterday and the day before yesterday of, what's going on in Maui as far as, well, I'm just going to take one aspect of this. What are we doing as far as behavioral health and mental health support in Maui? And what they're doing right now is at the shelters, they're basically deploying social workers, LCSWs, anybody really with mental health capabilities to kind of go from door to door in the shelters, in the hotels, and just find out, hey, how are you? Tell us how you're doing. Basically, strike up a conversation. And what they're finding out is when they feel that the person they're speaking with needs an actual consultation, there are psychiatrists on the ground ready to help. To what capacity? Not too sure yet. As far as the number of psychiatrists, I'm not too sure yet. But I know that some hospital facilities are sending their behavior specialists to Maui to at least start the process of getting them some help. Does that answer your question? At least part of it? Okay.
Could I add? Yeah, could I add to that too? So one of the things that I might suggest is really thinking about like where, and I come from, of course, the infant mental health world, so it's prenatal to 5, but I do think this expands to the entire age range of life, which is to help to like just think of where families and where people are. While there are a lot of people in the shelters, there are a lot of people who are not in the shelters. There are a lot of people who are living with other family members, living with friends, they're in Airbnbs. So while there's a great effort to centralize as best possible the response, there's still a greater need in the community to just reach the community. And what we're also finding is that families are leaving Maui because they were renting, for example, so they don't have to stay there. It's different if you own the house and now you want to go back and ensure certain things, but if you're renting, you can leave. So some of these families are actually going to neighbor islands, including Oahu, because of either greater opportunity or they just don't want to go back there. So I would encourage everyone to recognize that you may come across families and patients who have been impacted by this disaster probably more readily than you might think. So we really want to think about the support system around people, right? So typically the bigger systems are going to include your education system. And then if you can also find ways to just strengthen families, because when we take a look at the 3 of us who are talking today, what's the one common thread? Family, right? Everyone wants to be connected to their family. And I didn't know, but in Lahaina, I guess there's actually 40% of the population there is Filipino, identifies as Filipino. So that is a huge group of people. And so if we think about how important family is, can we find ways to build opportunities for families to reconnect, for families to become stronger so that they can take care of their children? As our friend was saying that, being able to take care of your own is really important also. So I think in terms of like developing supports, what kind of supports would be helpful? I think those are the things that I would really encourage taking a look at. As well as, primary care and your traditional Western mental health. as well as building in opportunities for cultural practices to be revived. There's a lot of healing just by doing the things that we often do. Okay, I'm just gonna be a little transparent here. I'm sure many of you have gone to get like a massage or cut your hair or get your nails done, right? Don't you tell these people your entire life? You tell these people all, I talk to my dentist while I can't even talk. And I tell my dentist my whole life, they know how many kids I have, they know what schools they go to, they know what my parents do. My dentist serves my entire family, my parents to my nephews and nieces. They ask me, how's your dad doing? How, you know, so everybody has the ability to build connection. And when we look at mental illness, a lot of times, not all mental illness, but certain ones really comes from a lack of connection. So when we can build connection, we can really build a lot of resiliency factors for our people. So just throwing it out there that there are many different ways to approach the situation. And if we can do it as a community, then we'll, I think we'll be more successful. Sorry, that was a long one.
I'd like to add to that too, and it's going to reflect pretty much what Erin and Gary have already mentioned, but I work in the prevention space. So one of the things that we've identified, normally for prevention, previously used to focus on risk factors and how to, try and lessen or decrease the risk factors, but that's really hard. How can you help a family who doesn't have a lot of income or who has previous health issues? So the focus right now is on focusing on strengths. And so going into the community and identifying the strengths in that community and actually building on that. So we actually have work we're doing right now statewide where we go into communities and then we work with the community. The community themselves identified what they need. We didn't go in and tell them what to do. They identified what they needed and then we work with them to recognize the needs in their communities. For example, families, there, but strength is the spiritual community. However you define spirituality, could be cultural, could be religion, but in Kalihi, we work with some of the ministers there because they are actually very open about mental health. That's not always the case, but two of the ministers we work with are actually want to do something about it. So identify strengths and then focus on that. The other thing too is for youth, we actually work with youth and because they're a resource as well. The youth will connect with other youth. So we work with them to identify their peers who need help and then get them the help that they need. Connect them, not themselves providing the help, that's asking too much. But recognizing a peer who's at risk and then getting them to adult who can get them the help that they need. So yeah, really reflective of what Gary and Erin said, just identifying strengths and then focusing on those strengths, could be it family, spirituality, peers, and then working on that. So that's another way of looking at it as well.
Did you panelists have questions for each other or things that you wanted to expand with one another? I know for me, one of my questions for Dr. Gary is, do you find it difficult to talk about mental health with people that are not in the same, like from the same cultural background as you in your practice? Because I know you probably get more than just Filipinos.
I find it easier, actually.
Oh.
I do. I guess, not having, apologies to my Filipino brothers and sisters, but I don't have to worry about your stigmas and your biases or your beliefs. I just kind of have to say, this is what I'm dealing with, and this is what you're dealing with, and now this is what we're going to do. So, yeah, easier, pretty much. That's kind of sad though, huh? So, yeah.
Well, I think what's great about that statement though is just the self-awareness that we have to have, right? That we are a certain something, whatever we are, and that we bring that into the work that we're doing and any conversation that we're having with somebody. So that self-awareness is really important when talking about mental health.
Agreed.
How much of the future education or future learning speaks to what I call language, because language is culture. For example, you tell me me a Filipino say stigma, hindi ko naintindihan yon. I don't understand that. When you say stigma, but it's there, right?
Yeah.
So something like that, or even resilience, we don't. So I don't know how far along is it in terms of, educating ourselves in the medical profession or psychology professions. How far is language access being handled, or culture?
I think it's huge, and admittedly, my Tagalog it used to be better. I'll just say that, yeah. Obviously, in Hawaii, the Ilocano population is by far the majority of the Filipino population here. I don't speak Ilocano, and unfortunately, the very few patients I have, we do have a lot of patients. The majority of them can speak English or Tagalog, and there's a very, very, very small population of those who can't speak English very well, but can only speak Ilocano. The challenge I have is how to get my message across. I'm very lucky to have a staff that speaks Ilocano, and I'm very lucky to have a nurse who is empathetic and knows how to not just translate for me, but just with her mannerisms and her mannerisms. I mean, just how she explains things. The parents seem to get it, and you kind of have to. You're not acting. You're just kind of. You're working with your nurse who speaks Ilocano to basically show your parent that, hey, this is what this is serious. And when I get that across, it does get through to them. So, but language is important. I regret not learning Ilocano. I regret not being stronger in my Tagalog, but I probably have to find a way to get that somewhere, somehow into my, arsenal, so to speak.
I'll joke about that because yesterday I just heard a story about one specific problem in Maui that they were trying to address a mentally ill elderly Filipina who also was deaf. So they couldn't find an interpreter who can speak Ilocano. But having said that, one of the policy things that went in my mind right away yesterday was in that student loan forgiveness program, put a premium for those who are certified interpreters or certified in the language. Maybe that can help increase the number of people or encourage more health providers or students in health to, make that effort.
It's a good point.
Yeah, to get some language.
Yeah, the Micronesian population faces the same issue that you're seeing. There's many Micronesians, there's Chuukese, Palawan, Pohnpeian, Marshallese, and we all speak different languages. So what I've noticed is that there's a lot of reliance on community people to help with that, and also community health workers to help those specific patients navigate the system. Because there's not many providers who are Micronesian. There's not many nurses. There's not many, actually, I can't think of any nurses. And I can think of a couple of doctors, but there's just not enough. So the way they get around, especially the community health centers, they rely on community health workers quite a bit. In fact, in Lahaina, KKV has been sending their community health workers, who's Marshallese and Chuukese, to Lahaina to help the Micronesian population there fill out their forms and provide translation services, because FEMA was a little too slow to get there. So they just we can't wait. We just got to get moving. So they did that. So that's one way to get around the language barrier.
Jesus. Hi, everybody. I'm just here to make an announcement that if you are flying back, there is a bus at 5:15, and you can meet at the elevators near registration, just if you're flying back.
If I could add one more thing to all of this as I'm listening, I've worked, as I shared, as a home visitor for many years, and I've, as a result, worked with families with many different languages and different cultural backgrounds. And trying to figure out how to communicate to someone who doesn't speak the same language as you is really hard. And so while not in a medical setting, what I could hopefully contribute is just really the way to build and to be genuine and authentic and to build trust with whomever you're speaking to will really be your biggest asset, regardless of language. Because as we know, nonverbal communication is actually the most effective and prevalent way that we communicate. It's the way we sit, the way we look at people, the way, and so there's certain nonverbal, we were talking as we're preparing for this panel about like eye contact. So that's a cultural thing. But so there are going to be certain cultural things, but for the most part, right? When you talk to somebody and you talk to somebody, they will be more willing to listen to you, even if what you say makes no sense to them, because they feel that you truly care about what their well-being is and what the outcome is going to be. So even if you don't have the right words, that's my 3-year-old's new thing. It's like, I don't have the words. You might not have the words in their language or even in your own language, right? But the way that we communicate and the way that we are and the way that we do the follow-ups, the way that we do all those things will hopefully help people do and access the specific care that they might need. And so too, I think when you do make referrals for mental health support, you want to be mindful of who you're referring to. Who are you referring to? Is this going to be a good fit for the person that I'm sending to you? And so those are just some of the things that I might suggest considering, because honestly, we don't always have the time to get the interpreter to the visit in order to have that communication happen, right? It's like all stars have to align to make that happen. If you're not fortunate enough to have somebody who can interpret in your office space. So sometimes you got to do it right then and there. And so those are the strategies that I might suggest, kind of just keep it in your back pocket, right? How can you communicate to this person that I really care about you and I really want the best for you. And this is hopefully a way for you to get the help that you need.
A question for all three of you. Has there been like a time where you had to, either with maybe people you've worked with or even your own families, where you've had to explain like mental health or and kind of like how you navigated through that, like a difficult conversation, especially if they don't necessarily believe in it, or like they're like, or your own family members, if they're like, what the heck are you doing? And then, yeah.
Renzi, to be clear, you mean my family or
Your
my?
family, yeah, like within your culture, people you knew, close friends.
But that they don't understand what the heck I'm doing?
and or like with mental health and
Oh,
like
yeah.
how you
I mean,
navigated that conversation.
I have. He'll be unnamed at this point, but I have a very good friend who just doesn't, his brother was depressed and came to me for help. And he just said, Gary, what is this? Like, this is all, in his words, BS, right?
Mm-hmm.
And I said, well, no, it's not. And he just had a hard time with it. He just couldn't wrap his head around it. It's very difficult dealing with friends and family. By the way, as doctors, we're not supposed to treat our own family members, which is very important. And so you always try to get someone else without a bias. But in this particular case, this friend of mine, when they need you for help, when they trust you, it's very hard trying to teach somebody you know very well about mental health, especially when they don't agree with it. It's when you say, hey, this is what I think, and you should just give it some consideration. There really is no good answer for that, Renzi. It's just one of those things where you just challenge yourself. It's a challenge for me. It was a challenge for me to get through to him. And the good thing is I eventually did. So, yeah. Anybody else?
Yeah, my story is, I had a really good friend of mine whose son died by suicide. And took place on the continent. And his sister blamed herself for it. They had just gone into a spat. And then he just went and took his own life. And before that, he hadn't shown any signs or symptoms. So it was completely by surprise. And it was a little frustrating because I'm trying to talk to my cousin. You guys need to, seek professional, you need to talk to somebody, can't hold it in. The thing for him though, is he was both a Pacific Islander and in the military. And he's like, I gotta keep everything close. I'm not gonna discuss anything. So I really couldn't get through. And unfortunately now the relationship between the sister and the parents is kind of strained because they just never addressed it. And I kind of actually really don't know how to, because I can't get them the help that they need. And they're actually moving off to Europe now, so even farther away from me. So yeah, it's a frustration that I think we all can relate to.
I think I have an interesting intersection for me because infant mental health is already something that people are like, what? And then when I talk about Native Hawaiian mental health, they're also like, yeah, no. So I kind of have it from two sides. And I remember I was doing a presentation once and I asked my family, I was like, do you guys even know what infant mental health is? And they're like, no. And I'm like, do you know that's my whole job? And they're like, yeah, we don't really know what you do. And so it's just kind of funny. And I said, I asked them, so I said, would you believe, because I have a 1-year-old and a 3-year-old, would you believe that they have mental health? And they said, no. If we didn't know you and you didn't talk to us all the time about these things, we wouldn't have thought anything. The kids, they're just going to grow up, they're going to do their thing, and that's it, right? And then we talk about mental health from a Native Hawaiian perspective. Well, what is that? And so, it is really tough. It is really tough. And so when you think about, I think the ways that I've gotten through to them, it's taken me a few years, but of really just this recognition that when we can take the time to take a look at our own lives, people will find that they've had mental health supports throughout their lives, and that's what's allowed them to be the person that they are today. And helping them identify that has been helpful for me, to help them recognize that, like, you also have mental health. And if you have mental health, then of course all the people around you have mental health. And I was actually just at a presentation this week, and somebody said, like, why is physical health and mental health like two separate things? Like, put the head back on the body is what she said. Put the head back on the body. And I was like, oh yeah, I never thought of it that way. But we really do seem to separate physical and mental health. And really so often aren't they actually connected, right? Of like, when you get nervous, like today, what's happening to me, my hands are really cold and I'm really thirsty all of a sudden. These are physical things that are happening to me. So why are we separating our physical and our mental states? And when we think about for me, when I think about and address Native Hawaiian stigma related to mental health, I just say, well, there's a couple of things. And one is that Native Hawaiians were very connected to their culture, to their land. They were very spiritual people. And we have lost all of that through cultural and historical trauma. And now it has been replaced by someone else's culture, someone else's religion, someone else's something, and we've lost that connection. So now we have a different experience. And then also, as I was talking to somebody, a kupuna actually told me that there are Native Hawaiian healing practices, and there are some that are not going to address certain things. And they said, modern problem requires a modern solution. So yeah, Native Hawaiians maybe didn't have mental health therapists back in the day, but there wasn't a need for them because their situation and their life was different than it is today. So that was, I've always heard that and really thought about how, our kupuna didn't know how to deal with substance use because there was no substances to be abused. So this was a different world that they lived in. So just some of the things that, yeah, we should hang out. And then, yeah, you get to hear all these kind of thoughts. But yes, lots of things to battle, I think, within our own families to share.
I feel like, oh, thank you. A lot of what you said, right, is terminology, and we talked about language. So I feel like you might say to someone, do you know infants have mental health? And they might say, no, they have no idea what you're talking about. But as you talk to someone and you get to know them and they understand what you're talking about, like in your presentation, you made it very simple to understand. You have bonds with your mother, your father, your caregiver, whoever it is, and those bonds are important to the child as they develop. And when you explain it that way, I'm sure that resonates with them, right? So it goes back to, it's not that they don't believe that kids have mental health, it's that they don't see it as mental health. But when you explain it the way that you do, then they understand, right?
Absolutely.
That's it for time. I'd like to give another thank you to our speakers, Erin, Dr. Gary, and Dave. Thank you so much. And then
Yeah, everybody. So just another reminder, if you are flying out, there's a bus at 5:15. So you can meet at the elevators near registration for that. And then there's another opportunity to view the research posters. And I'm pretty sure there's a raffle if, yeah, raffle after this. Thank you, everybody.
Huh? Almost like to be reaching out to the organizers. What it is, this is I work with actually, I'm 20 months now in the adult mental health division.
Oh,
But
okay.
more as a planner, I'm not the adult.
Oh.
Gmail. There you go. That's me.